All right. Well, thank you everybody for joining us today. Really excited to discuss the emerging trends, best practices, and innovations that are happening right now in diabetes self-management, moving the conversation from just management itself to inspiring prevention, control, and reversal. So really looking forward to moving through this. As far as who I am, I'm Joel Hungate. I'm director of Hancock Wellness and our employer strategy group at Hancock Health. And I've been working in and around innovation in healthcare my entire career. So it's really exciting to be on the provider side, and in particular, start to talk about how that innovative approach is starting to help us overcome the challenge, the burden of creating opportunity around moving the needle on chronic conditions. In particular, my challenge today for everybody watching is going to be to reframe the problem of diabetes, really push yourself to ask the next best question as we think about innovating our approaches to addressing these issues, embracing the concept of opportunity surface area, and really innovating where you're at. You know, you have the ability to innovate and make a difference no matter what your circumstance, if you have this kind of thought process and this best practices to wrap the right types of engagement around folks in our community, in our organizations, on our teams, in our sphere of influence, around the concept of inspiring prevention, control, and reversal with diabetes. So as far as reframing the impact of diabetes, we all know that it's been exacerbated by the pandemic. That's not news for anybody. But the second wave that's coming that I think is going to be really interesting and potentially even worse is the idea that because of all the care that was foregone due to the pandemic, the world being temporarily closed, we're seeing that patient acuity is higher. They're presenting with more complex issues, more multi-morbidity. And in addition to the chronic conditions that they're showing up with and the propensity for obesity and other conditions, we're also seeing folks struggling with the recessionary pressures and the economic impacts that we're seeing right now. In turn, that's also being compounded by the influx of ultra high deductible plans that have much lower premiums that people are opting for because of the economic pressures. And what is happening is that we're seeing the manifestation of foregoing proactive preventative care on top of not pursuing that care for financial reasons, turning into a snowball effect. And this is really manifesting in the space of diabetes in particular. You know, we look at just for the 2020 data, deaths for which diabetes was the underlying cause had spiked from the trends and the lowering that we had seen since really around 2009 to almost the largest increase of anything from 2019 to 2020, second only to accidents and overdose, would be the change in diabetes-related deaths at roughly 17% in 2020. So we're seeing these spikes. We're starting to bear that out, and we start to look at this regionally. And I'm going to pick on Indiana because I live in Indiana. But from a Midwest, these trends do hold from a Midwest perspective. That diabetes it's multifactorial. You know, when we see these obesity, hypertension, cardiovascular disease, smoking, physical deconditioning, poor diet, food insecurity, socioeconomic status, and social determinants of health, all of this complicate or contribute to diabetes. And I mentioned it's only going to get exacerbated by the fact that patient acuity continues to go up, and unmitigated chronic conditions and diabetes in this situation catalyze poor, costly outcomes. So we all know that there's billions of dollars at stake here, that the outcomes snowball and compound over time. And when we look at diabetes in the United States, we're also probably familiar that you pay 2.3 to 2.5 times more if you're an employer in total cost of care for diabetic patients relative to a non-diabetic population. So of course we want to manage our diabetes, and care compliance with anti-diabetic medication is creating some positive momentum and clinical inertia on the outcome side. But we need to start to think and ask even the next best question on this, because right now employers are bearing that direct and indirect burden to the tune of $90+ billion, and it affects the plan premiums. It puts the employer, the individual, at risk for not just the physical cost of the plan, but absenteeism, loss of productivity, inability to work, loss of engagement, failure to attract and retain healthier employees. So the stakes are high. And when we talk about diabetes, here's what people think, right? Now we get the Wilford Brimley, the stigma around, diabetes. We want to start to reframe this as not a disease that defines the individual or stigmatizes the individual, but rather it's a continuum, people being on a journey. Now, when you're an employer, what do you feel when you think about this? If you're looking at hiring, if you're watching your claims and utilization rise and watching the cost of diabetic medication, and watching the medical spend skyrocket. This is how the employers feel. It reminds me, using meme literacy theme here, it's the dog saying, "This is fine," in the burning room. So what are we doing to really move the needle on how we're addressing this, how we're thinking about it? Because it's not just a community health issue and an individual health issue. It's a barrier to economic and workforce development. It's becoming an anchor issue, and we've got a lot of work to do. In particular, as we look at the Midwest and Indiana, according to this graph, we're starting to be above trend for the United States, and we need to start rethinking and reframing the concept of self-management because of that. So you might be wondering, well, how do you define diabetes self-management? And it really is care compliance is the term that's been defining that for the longest time. And my question to everyone would be, is care compliance enough? Because right now, if you look at our current approach, care compliance could be educating and managing comorbidities and prescribing medications to help them manage their diabetes in some way, shape, or form, suggesting exercise and or nutrition through some sort of external, hey, go find it yourself, you need to eat better, move more, and measure / hope for compliance with that. Take your medications and hope that you actually do the things that we've asked you to do from a care compliance standpoint. But the big question becomes, are we willing to just continue to repeat this cycle and hope for compliance and hope for change, as opposed to starting to think about this under the guise of prevention, control, and reversal? Because we're having to address things, not just the issues that they present with, but the socioeconomic barriers, isolation, stigma, concomitant issues, deconditioning, frustration, lack of knowledge, food insecurity, cost of care. All of this means our definition must expand. It's a multifactorial problem, like we discussed before, and it requires a probabilistic, multifaceted, multi-touchpoint solution. So I'm an engineer by trade, and what that means to me is that we need to start to create the infrastructure that creates these multiple touch points, that addresses these barriers and wraps that around the individuals that are battling diabetes, so that we can create cross-functional collaboration, integration for that clinical inertia, that momentum to prevent, control, and reverse, and have a mindset focused on that, not just managing conditions, because health needs to be a means, not an end. If health was sufficient end state for all of us, if it was sufficient end suggestion for all of us, we'd all be a lot healthier, right? For the sake of being healthy, but we're not. It needs to be a means that unlocks quality of life, community, opportunity, experience for folks. And that's where we want to create this practical framework for success, where we can wrap well-being around the continuum of diabetic risk. So here's how we're doing that. We use physical activity, clinical integration, nutrition. And if you can do this, if you can align these resources in a way that's engaging, that's innovative, that is empowering for the people battling with diabetes on this continuum of care, you can start to create sustainable lifestyle change. And what that looks like, you really have to rethink diabetes self-management of who, what, and why, right? What stages are we really targeting? Prevention, pre-diabetes, and diabetes, and having strategies specific to those. Creating cross-functional collaboration where we think more of an ecosystem, not a carousel, right? More touch points, more opportunity surface area to make better choices for our health and well-being over the long haul. And really diving into the strategy and mindset for the practitioner. Granting nutritional insights, physical activity, and a glimpse into that mindset of how do you empower the patient, the person, families, communities to build hope, trust, and momentum. So here's how that can look. If you're dealing with prevention, reminder, everybody's at risk for diabetes, every single one of us. So we want to create access points and engagement well before the pre-diabetes risk stage, because everyone who is not pre-diabetic or diabetic falls into this category. So getting them in touch with and enculturating guided physical activity to address general deconditioning, create accountability, and have prevention-driven touch points for nutrition. If we can enculturate this prevention, this mindset of prevention while time is on our side, we think about this as an investment, connecting folks in primary care, wellness settings, dietitians, and rehabilitation to not forego the idea that nutrition, physical activity helps us keep the risk for diabetes at bay, in addition to our relationship with food and how we're managing and enculturating these best practices. So think about that as the investment stage. And then there's the pre-diabetes population, where 90 million plus in the US are pre-diabetic and 80% don't know it. That stat always just baffles me. We think about what a looming problem that we have, and most aren't even aware that they're at risk. So really increasing education, urgency, and access points to drive action. For anybody that's in that pre-diabetic and comorbid risk factor category, again, how can we connect them to guided physical activity for deconditioning, prediabetes, obesity, connect them to diabetes prevention program, and have reversal-driven medical nutrition therapy or nutrition touch points to help, as appropriate, manage or reduce weight, establish a framework of accountability for diet and exercise, shift back into prevention so that we don't get into the diagnosis of diabetes. And the mindset here is urgency. And it's all the stakeholders, all of the touch points in the primary care, the proactive continuum, but also the stakeholders like the employers themselves to say, what are we doing to help manage the risk in our population that is pre-diabetic and they don't even know it? And then finally, the diabetes population. We don't want to settle for management. We want to control and reverse when possible. Now, complete reversal, depending on how long they've been battling type 2 diabetes in particular, may or may not be possible, but we can reverse the trajectory of the disease. So it's not just the exogenous insulin intake arms race that ends up happening by just continuing to manage the condition. How can we address the underlying sustainable lifestyle changes that need to happen? And the mindset here is empathy and hope, where that guided physical activity for deconditioning, diabetes, and obesity needs to be a mainstay of our approach, but using diabetes self-management training, control and reversal-driven medical nutrition therapy, and tagging in endocrinology and remote monitoring technologies and care compliance around medication to create and sustain momentum and hope for somebody that has been diagnosed with diabetes. So this is the outcomes that we've seen when we do this sort of thing. We've seen a 1.5% drop in A1C. Folks that come into our physician referral programs in our settings and in settings that have enculturated physical activity, nutrition, and clinical integration, we've seen them enter diabetic and leave pre-diabetic or non-diabetic off of medication. We've seen meaningful drops in systolic and diastolic blood pressure. We've seen real recomposition of body fat into muscle, where you lose visceral body fat, but ultimately gaining that internal locus of control with accountability and community and support. That's what arms people to make the changes that matter and sustain them. And that ecosystem, it's up to us. You can create this right where you're at with whatever resources that are at your disposal, because those best practices are all tailored around an engaged ecosystem with stakeholders. You want to fight fragmentation and silos. We all need to be in this together and working on this together in a way that allows us to not only enculturate the changes that need to happen, but connect the dots on collaboration standpoint. Likewise, we need to win the battle of engagement and empowerment to create clinical inertia so that it's not just one touch point, it's integrated touch points, creating opportunity surface area for everyone involved. Because the more that we can enculturate and create positive touch points for sustainable lifestyle change, the more likely we are to create lasting momentum. Having some sort of intervention and mindset around this where we let the disease define the person, you're diabetic and you're just going to have to manage your condition. No, that's like telling people, hey, we're going to help you put out the fire in your house, but never rebuild the house. You're going to live in this hollowed out, charred husk of a home for the rest of your life, because we're not going to try and fix the underlying issues and rebuild back to what healthy and well can be for you, right? We don't want to just stop at managing the conditions and care compliance around just take your medication and we'll do this over time forever. What if we could start to address those underlying issues and improve quality of life? And that's ultimately where you can innovate where you're at. Creating this opportunity surface area, not just compliance, create this framework for consistent physical activity, tailor nutrition, weight reduction, management, and recomposition as appropriate. Clinical oversight and integration are key, as is clinician buy-in and referral ecosystem to get folks connected together, not fragmented. Likewise, we need to optimize the experience, creating trust, accountability, community, and really honoring folks' time and their commitment to this and asking that next best question, measuring what matters, addressing root causes, but aligning incentives and creating something new. That's what we all have the opportunity to do, because we're all a catalyst for change. So don't ever write off your ability to impact and create real change, because you can be that catalyst to help prevent, control, and reverse diabetes in your individuals, families, communities, people, anyone in your sphere of influence. And you can do that by creating innovative access to this infrastructure of well-being conversation. That's the multiple touch points. That's a way that we can do it. We've seen the results bear out. And the more that we enculturate this approach, the more we can create empathy, hope, and progress and clinical inertia, sustained momentum for folks battling diabetes. So I thank you for your time. Really appreciate what you do every single day. And I hope that this helps us start to reframe the way that we're thinking about the battle with diabetes, that we're all in this continuum, and that we can move the needle towards prevention, control, and reversal.